we are very fortunate to have two of our very own members here talking about how things are going with COVID. And when I do introductions for the programs or the guest speakers, I usually like to just kind of point to their the way that they live a Rotary motto of service above self. And all of our members are awesome, but Dan Robie and Dr. Dan Robie and Dr. Bruce Maddern are just above and beyond Rotarians that touch your heart with service. They not only do it with their job, but they volunteer in the community. And I know that when I needed help, they were personally there for me. Dan was there and he helped with many questions as Peter was going through what he went through. And then as I have had exchange students and needed doctors to help and do things, Dr. Bruce Maddern was right there. And I am just so grateful that they're part of our Rotary family. And with that, I'm going to turn it over to whichever one is going to speak first.
Well, let me kind of get started. And first of all, let me thank Bea for that lovely introduction. It's a privilege to be part of this group, as you guys know. So let me give you the history of how this started. We had our board meeting at San Jose Country Club a couple weeks ago, and it was very noticeable to me how everybody was trying to wear their masks and how different the world is because of the COVID thing. And I was talking to Tom about maybe we could do something as a program to kind of update people where we are, allow people to ask some questions, talk to Dan about that. We all thought that was a good idea, and kind of here we are. So that's how we got this far with some of that. So what you're going to see is a little bit of a PowerPoint presentation, but the attempt here is to keep it topic oriented, and whatever questions you have, this is really intended to be kind of an open forum to discuss. We'll do the best we can to kind of answer your questions and also kind of update you on kind of where we are both locally, nationally, and I'm going to have to say internationally as well. So that's kind of the intro to the whole thing here in terms of how we've kind of got started. So let me go ahead and crank this up. Dan, you can add whatever you'd like there.
Now go ahead and get started. Bruce and his daughter, you guys made these beautiful slides. And I have several things I'll add in periodically, but I'm just gonna let you run with it, Bruce, please.
We're getting the slides up here.
There's so many topics while they're getting the slides up that we could have covered today. You're gonna get a broad brush stroke, I think, and then we can get down into the nitty-gritty details as much as we want. We can go into immunology if we want to. We can go into critical care medicine if we want to. So many different things. So hopefully there'll be allowed 10, 15 minutes for questions at the end.
All right. Is everybody see that? Are we up and going here?
Yes.
Okay, awesome.
Yes. You're good.
All right. So you guys kind of know who we are. I'm going to give you a little bit more of an introduction, at least about myself. So I'm a pediatric otolaryngologist. That's an ear, nose, and throat guy. And somewhat uniquely, ear, nose, and throat folks have had a lot of challenges with this because when we see kids or adults, we are in everybody's faces. And so any kind of aerosols and droplets, ENT has been, I would say, harder hit with COVID-related issues than perhaps some other physicians, both as being statistics in the healthcare crisis, but also with how we've had to manage our offices. So a lot of us in ENT have had to take it upon ourselves to keep really updated with some of this stuff. So that's kind of the intro to at least kind of where we are from that standpoint. Okay, so I'm going to say welcome to the pandemic. This is not a new thing. There are other varieties of this coronavirus that have been around before, 2003 and 2012. They are cousins, very close cousins of the current virus. There are some significant differences for what's happened in those previous epidemics and why this is a worldwide pandemic. Among them are how contagious this particular virus is, and it is somewhat different than the other two that have been out there, and how we have handled it. And then what we're going to talk about a lot, frankly, is this S protein that's on the virus, which is really going to be the crux of how we're going to get to really what I'll say the the prevention is, which is going to be the vaccine as we go forward. This slide is already out of date. There are well more than 10 million people worldwide infected. We actually don't know the number because a lot of countries do not report very well, seriously underreport, or frankly fail to report at all because politically it's not in their interest. And so likewise, we really do not have a handle on the total number of worldwide deaths. So somewhere well north of that is probably where we are, but a horribly underreported illness. And as those of you keep up with the world news, there are some places that are much worse hotspots in the world. I'll mention South Africa, Brazil, other places currently that are having extreme difficulties with this from a seriousness of illness and frankly mortality. So locally, we'll turn to kind of local issues, is we have a quite robust emergency medical plan for the city. And all the hospitals and local healthcare institutions are part of a mandatory emergency management plan. So the surgery center that I manage is also part of that emergency management plan. And so the beds that we have in our own surgery center could be used as ICU beds if called upon. And as Dan knows, hospitals likewise are part of a very large, robust emergency management system. As part of that, JFRD reports to us daily as to what's going on currently on a day-to-day basis, bed-by-bed basis in our own community. So I'm going to show you what is a daily impact report and try to explain some of that. In addition, I want to mention that we have a kind of a numerator and denominator problem. So as you view the news and you hear numbers, it is very important to not just hear what the number is, but what the denominator would be as part of that in terms of a local impact or any data that you tend to see, and tend to look at that with, I'll say, a little bit of a jaded eye. So this is what a daily report looks like. This is actually from last week. So I think you can see some of those numbers. I don't expect everybody to see all of them and how well it magnifies on your individual screen. But where's the mouse? Okay, so I'm going to try and mouse some of this, but you'll see all the Duval County hospitals listed, total number of beds. We have about 3,000 acute hospital beds in town. Last week at this time, there were 2,400 out of 2,900 beds occupied, for a total occupancy rate of about 82% for all causes. Of that, about 500 or so last week were occupied because of COVID-related issues. It's about 20%. There are about 450 ICU beds in town, of which the capacity at that time was about 78%, of which maybe 20 to 30% were actually occupied by COVID-related issues. This even counts the total number of ventilators that are being used and the available ventilators that we have in the community that we can actually resort to if we had to. So total number of ventilators. You can see where ICU capacity is, and you can track daily rates for positive cases. The numerator here is interesting because Florida at the moment is testing about 120,000 patients per day. So you can use that as kind of a numerator to some extent of kind of where we are, okay? So that you can see how well we can kind of track our own local issues, and you can infer that to kind of how we're doing relative to kind of other places, okay? All right, so 2,900 beds, 83% occupied. We have some capacity. In addition to that, because of kind of local and state politics, hospitals have elected, and they're allowed to, in concert with the state and regulatory agencies, to either turn on or turn off elective surgery. So as a lot of you have heard, the bed occupancy rate is roughly a lot due to what Dan and I do on an everyday basis in occupying beds within hospitals. And so a lot of the total occupancy in hospitals, probably 30 to 40% total, is probably elective surgery. So some of those beds can be, I'll say, turned on or turned off for other needs, depending on how that goes. It's very disruptive to hospitals, but we can go ahead and do that if need be. Transmission. So this is clearly something that's passed on face to face. You have to get close to somebody. You've got to spread an aerosol. You've got to spread some kind of a droplet kind of thing to be able to pass this from folks to folks. An awful lot of news is about face-to-face transmission. I want to remind people about how important hand-to-mouth transmission is. It's not just wearing a mask. It's washing your hands about 10 times a day. Welcome to Dan and my world about keeping your face covered and your hands clean. There's fundamentally a difference between droplets and aerosols. Droplets are big particles that fall very quickly to the ground. Aerosols are the ones that are very micro particles that get spread over different distances. Think coughing, sneezing, and sad to say, singing. So some of those will spread particles far and wide. And so that's why, by convention, not by terribly good science, we've agreed to have a 6-foot distancing kind of arrangement. That comes to mind because of the aerosol type of problems that we have. Surfaces, a lot has been made of that. How long does COVID last on different surfaces? There's probably not a lot of truth to that being spread from person to person by way of surfaces. Much more of it is kind of hand to mouth and face to face. A lot has been said about transmission occurring in pre-symptomatic carriers. I'll come back to that part a little bit. Contagion and viral shedding. So just how the virus works. So we have a max viral load with the onset of symptoms. So when you begin to get sick is actually when you kind of shed most of the virus. But the problem is you can begin to shed it 2 or 3 days prior to getting symptoms, and you can continue to shed it maybe 8 to 10 days after you feel better. So about 97% of the time you develop symptoms within 10 or 11 days of actually exposure. The average is only 5 days. But that's why we have a 14-day rule that's still roughly out there. Employers, CDC, that gets modified from time to time, but roughly someplace in there. I think most folks know some of those things. Severity is really very location dependent and availability of healthcare. I mentioned South Africa, I mentioned Brazil, other places, Mexico, things like that. So we are very fortunate in our local community to have very good healthcare. The availability, ICU beds, ventilators, PPE, all those things that go into it really have a lot to do about how well we can take care of each other in our own local community. To that extent, it's a local disease. As folks know, there's a lot to be said about comorbidities and probably not enough said about it as individual risk factors to ourselves. Age being the biggest one, but everybody's heard about hypertension, cardiovascular disease, COPD. Not enough has been said about obesity and sleep apnea, I'm sad to say. And then immunocompromised patients for whatever kind, they are much higher risk for what goes on. To that extent, maybe 60 to 90% of hospitalized patients are at some kind of a risk that having 2 or more risk factors. So we know enough about the illness now that relatively healthy folks under age 65 or so roughly have a very low probability of having severity of illness, notwithstanding the other risk factors that are out there. In addition to that, children do not terribly seem to be affected. They do not manifest the same kind of symptoms. The youngest death so far in Florida has actually been here in Putnam County, was a 9-year-old. But I think there were other risk factors with that particular patient. Roughly speaking, kids they don't get it like we do, and they don't pass it like we do, and hence the conversation and the intense political debate about schools and attendance and that stuff. From a case fatality standpoint, you can see the difference down there. It's 1,000 to 10,000 times more of a risk if you're 85 and above than if you're 17 and under. Testing, what a hot mess that one is. We got a whole lot of false positives. Some of it has to do with testing techniques, laboratories, laboratory errors. Everybody has heard all kinds of problems with testing. All those stories are true. We, in the medical side of this, it's a headache every day trying to deal with it, especially on the surgical side of things, and trying to make sure that both staff is healthy and also whether our patients are really positive or negative. It is a tremendous problem in healthcare at the moment, with not a good outcome for the moment either. roughly speaking, two kinds of testing, as folks know. There's the RNA or PCR test, which actually looks for the actual genetic material from the virus. You can get that from a nasal, oral, or a deep nasal swab. But the key there is you have to get a vigorous swab of whatever area that is. Then that is much more likely to give you some type of a positive test. What folks don't think of sometimes, you have to wait 3 or 4 days after symptoms before you're likely to get a positive test. If it's the first day, it's not as likely. 3 to 5 days into it, you're much more likely to get a positive test if there is virus around. Antibody testing, the easier of the two, is a simple blood test, just 1 drop of blood. And it really just tests for the presence of immunity, both early and we hope late-term immunity, so-called IgM and IgG. And again, there's quite a bit of politics at the moment surrounding some of the testing issues. Lot J, what we're doing in town, who's paying for what, pre-op testing, it's acutely a hot mess at the moment. So some of the testing issues, the availability of testing, employers are trying to be very nice with their employees, I'll say most of the time, being both available to have tests, but also to kind of protect their employees about when employees come back to work. And so the necessity of having a positive test and then necessity of having a negative test to be able to come back to work versus just waiting 3 to 5 days when you're asymptomatic. And again, because of the testing problem, it's very hard to both get tests, who's paying for them, and how is that working in the marketplace with employers and employees. Who should be tested, who is really at risk, and then the distinction between a symptomatic person versus pre-symptomatic. Treatment. So most treatment is really just supportive care. If you take a look at emergency room numbers, they turn away 80 to 90% of people who come in fact, are positive. Most folks can take care of themselves at home. They can just rely on what you basically do with the flu, which is rest and fluids. The hard part in the ER is making the distinction between who is really mild to moderate and versus who is somebody really severe and whether or not somebody really has to be admitted. Even if somebody is admitted these days, most folks who are being admitted do not wind up in the ICU. They wind up on the medical floors being treated with supportive care, which is stuff like oxygen, respiratory support, things like that. Very few folks, unless you have significant risk factors, including age, wind up in the ICU. Dan, I'll let you comment on the ECMO part of it, since that's kind of your bailiwick, if you want to go ahead and do that.
Sure. So ECMO is what I would consider the most advanced, most aggressive, most invasive type of support that we can do in a medical center. It is similar to cardiac bypass during open heart surgery, but that's made to be a short-term intervention versus ECMO. We can have patients on ECMO over a month. You probably recently heard about that Broadway actor that died despite having a prolonged run of ECMO. And he died for various reasons, but nonetheless, he was, the attempt to save his life included ECMO. So it's very advanced. There's an oxygenator, there's a pump. Nowadays, we usually use a centrifugal pump versus the old-fashioned roller pump. And there is an arterial cannula and a venous cannula. If you're using the arteries and the veins, what we call VA ECMO. And if you're using just the veins, you can go veno-venous ECMO. And that's where, for example, you take blood from a large cannula placed into the right internal jugular vein, and then you reinstill it into the leg via a large cannula into the right femoral or left femoral vein. And that cannula goes all the way up to the level of the heart. So you're taking blood and then oxygenating it, removing CO2, and then pumping it back into the body through either another vein or for via ECMO into an artery. But it's highly advanced and it's highly invasive.
So I kind of cruised by a lot of the other, I'll say, on either end of the treatment spectrum stuff that's out there. I'll, whatever kind of questions we can ask about, whatever comes up with you guys, happy to kind of answer as best as we can. But among the other things that are out there that have been tried and have some success would be the use of just non-steroidals such as Advil, Motrin, Aleve, stuff like that. A lot of news about remdesivir. Hyperimmune globulins, people who have had the disease before, if you go ahead and go to the blood bank, you can siphon off basically their immune globulins, which are very powerful and can be used for very severe cases. The politics around hydroxychloroquine, I'll just mention that for a moment. So I would dare say that most physicians that are in the trenches have a stash of hydroxychloroquine around someplace, and have tended to use it, at least the ones that I know that are highly at risk for doing this. The reasoning would be this: if you ask most cardiologists if they take an aspirin every day and does it help prevent cardiac disease, they would tell you probably. And with that in mind, they tend to do something like aspirin. So the same is also true with hydroxychloroquine. It has some benefit probably on a prevention basis. And if you really are working in an intense environment and or likely to encounter it, I would say most physicians that I know have either have a stash of it or in fact have used it. So that was kind of the background, notwithstanding the politics of the hydroxychloroquine. There are some other medicines that are out there now that are called monoclonal antibody type of medications. They're used for severe rheumatoid type illnesses that really have a lot of benefit in severe cases. So in addition to steroids, there are some other very significant medications that are not antiviral medicines. They're really anti-inflammatory medicines that have a tremendous benefit and have really brought down the severe mortality and ICU stays. They have shortened the amount of time in an ICU and also the amount of time that you're going to be on a ventilator. So we have some other very significant therapeutic measures that we can use these days that we now know did not know 3 or 4 months ago. And that's why you'll see some of the data being skewed, because we have people in hospitals on the floor, but we don't necessarily have them on ventilators and in the ICUs. So that's kind of where we are at the moment with kind of the treatment side of it. And then the big topic now is vaccines. So I wasn't smart enough to buy Moderna back in March. Maybe some of you were, but there are a variety of private-public partnerships with some significant hope in the very near future for vaccines. So the vaccines come in roughly 2 types. Think influenza, and then think something that's entirely new that's kind of genetically based. So classic vaccines that we use now, the ones we do for influenza that we're supposed to get every year, basically use what's called an attenuated virus, which is a virus that's kind of beat up that can hold onto an S protein or some type of protein that's on the virus that you're trying to protect yourself against. In this case, coronavirus has those little spikes. That's why they call it the coronavirus. And so all these vaccines are going to try and protect you by working against that S protein. So the classic type of vaccine is you take the S protein, you hook it onto an almost dead virus, then you inject that into somebody, and then you can turn your own system to produce antibodies against the S protein. That's the classic style. The new one that's out there that folks may have heard is called mRNA, where you take the actual RNA from the virus, insert it, tag it to another virus that will go into people's immune system, and then you can make the immunoglobulin without having to have the reaction to it. And that Moderna is one of those. There's another one that's out there that's the mRNA type, and that is will be the real breakthrough with this at some point in time. So there are 2 type of competing styles of vaccines. There's a tremendous competition between the US, European Union, and I'll mention China, and in terms of who's going to be first to the market, but also the efficacy of this, and a lot of news around that. So it's really a race to the market. And as you know, politics is heavily involved here, that will have a lot to do with success, as well as the politics of it and the economic success worldwide about getting vaccine to market. So most of these companies already have factories in place. They're getting ready to plug in what will be the sequence to make the actual vaccine. So they're roughly 80% ready to go once a vaccine is proven to be effective. So what was announced yesterday was several large 30,000 plus enrollees that have to come to be able to prove the safety and efficacy of the virus, but there's very strong evidence that's where we're going to be. And then, frankly, the making of the virus itself, at some point, the actual production of it, is these companies are already geared up. So that part will not take very long to get it actually to the marketplace, meaning to individuals and primary care providers and those who are going to dispense the virus actually. PPE and all that stuff. So an intense amount of social discussion about some of that. And what we have learned over the past 3 to 4 months, no one would ever have guessed. So the mask and how important that is, social distancing and the amount of space between people, and then hand washing. Those are the big three. So a lot has been made talk about masks. I'm going to mention social distancing for a little bit here. There's no magic about the 6-foot rule. That was decided upon, I'll say, somewhat empirically based on some evidence, but we kind of adopted that. But it's already been changed in a lot of other countries when it comes to schools. So if you watch what happens with schools in Europe, for instance, they have arbitrarily changed the 6-foot rule because it was in their best interest. So somebody figured out you can put 50 to 75% more kids in a classroom if you just change the social distancing rule from 6 feet to 3 to 4 feet. So guess what? That's what they have done. So I would expect there'll be some noise about social distancing and how much that is even over here as we begin to grapple with the school issues, but there's nothing magic about the 6-foot rule per se. What's more important is the mask. There's a lot of information about how important masks are, both to prevent the transmission to others, but also how much it would protect you while wearing it. Enter the politics of the situation and who's going to wear a mask and when. The type of mask does make a big difference in terms of cloth versus paper. The N95 mask just means 95% of the particles that are certain micron size get removed, but unless you wear it correctly, it doesn't make any difference. So you've got to wear it so you can not leak air around it. And so to some extent, the kind of paper, I'll say surgical masks that we've been using for years and years do a somewhat better job than the cloth masks that you kind of see out there in the market every day that you see for sale on TV. I see kids every day in the office that now have, superpower masks and superheroes on them that for the kids to wear. It's better for them to wear, but they're not terribly effective per se. And again, I'm going to put a plug in here for the hand washing part of it too. When you touch your mask with your hands, what are you going to do? You're going to exchange material. So the more you wash your hands, in addition to just wearing the mask, it also has a lot to do with where you are. So contact with different surfaces, hand wash kind of stuff, rubbing your nose, doing those kind of things are very effective ways of kind of transmitting this kind of stuff. And so we have to keep that in mind as we go about our day-to-day business. And just to show you how far back this goes, take a look at this picture. This is a true picture from 1918, and I had the focus on the cat. So this is not new. So this goes back, and there's a lot of people know about the 1918 Spanish flu and how devastating that was. Well, it was very true. And one of the things they learned even way back then, we are not reinventing the wheel here, is to get folks to wear a mask. It makes a lot of difference, okay? At our house, our cat does not wear a mask, I'll say that. In addition to all this other stuff, we've learned a lot about what I'm going to say is genetic and socioeconomic disparities. And we've talked about some of these kind of health issues with the club at different meetings for years, some of the projects that we get involved with, and this is very much in line with that. So we know, for instance, that genetically speaking, that certain racial populations are more prone to certain illnesses. Black Americans, for instance, are much more prone to asthma anyway. So that part is very well known. Latinos, likewise. So some of those things go into our genetic makeup in terms of, are we likely to get more illnesses or not? That goes back to thousands of years of DNA and genetics and the rest of it. Throw that into the mix with also socioeconomic kind of disparities, and that was the mix of stuff that you saw in New York. where some of those folks are very disadvantaged, both genetically and socioeconomically. It was a perfect storm. You throw population density into there, and that's why New York had such a hard time. And at that point in time, several months ago, we did not know the importance of nor reinforced, I'll say, masks. So at that point, we were passing the virus around very effectively. In addition, a lot of cultures have multi-generational living. So Italy, for instance, lots of folks lived in the same household. They're also very touchy-feely, as most Italian Americans know. It was very effective at passing the virus around, and that is a good reason for why Italy was so hard, the virus was so hard there. So the other concept for societal components would be kind of horizontal versus vertical living. So New York City is very vertical, meaning subways, mass transit, and elevators. Here in North Florida, we tend to be somewhat horizontal, where we're kind of spread out. We are not big users of mass transit. So aside from the occasional Jaguars game, we're not that close to each other per se. Churches, other aggregations are, kind of uniquely affected, and we're struggling with that. But by and large, we have a more horizontal type of living environment here in North Florida. Other challenges. This is where Rotary comes in. Is that at this point, I'll make the statement, this is more of a political illness than a medical one. We understand what the illness does medically. It's whether or not we have the political wherewithal to make the changes that we need to and to stick to them. So among which are masking is really quite effective at preventing the transmission of a lot of the virus person to person. It's whether or not we're politically or socially willing to wear them as often as we need to, and then to wash your hands. So I mentioned that as more of a political, social challenge than really a medical side to it. We had the issue of what is the lockdown versus how we opened up. And again, that's a political challenge, the economics of it, and people and small businesses and employment and unemployment and employees and how we tend to treat each other. Those are really quite significant conversations. We're happy to talk about it, but no particular answers there. Schools will be the biggest challenge because parents really need to go back to work. And I dare say most parents, when I see them in the office, would be very willing to have their kids to go back to school. They've had enough by right now. So they want their kids to kind of go back to school in a safe fashion. It's also much better for early childhood development, significantly better for early childhood development, for kids to be back in school so they can kind of mix it up with other kids, that type of environment, learn the appropriate social kind of behavioral elements that school teaches at each year. And if we lose a year, kids will lose that experience, and it'll be much harder for kids to catch up. So that's where a lot of children's health providers, and including the American Academy of Pediatrics, have come out very strongly saying kids really need to go back to school in some fashion. Again, the question is how safely. Large gatherings, we struggle with that. So church, I mentioned singing as being quite a risk factor for aerosols. Unfortunately, that's true. The Jaguars, notwithstanding their recent record over the past 5 or 10 years, I'm not sure anybody wants to go back and watch them, but we'll see how that kind of works as things kind of come up. I mentioned reporting in terms of kind of how you watch the news. I mentioned the issue before of kind of what I call the numerator and denominator issue. You really have to watch some of the numbers that kind of go on to really determine what is kind of either risk or how communities are doing. The experience in Florida has not been like New York. It never will be. We are going to have spikes for what we're doing. Different communities are going to have to go through this. I'm not sure that our public health officials or politicians have been quite as honest about reporting. I'll mention it that way. So when they said flatten the curve, they failed to mention the second half of that, which is we're still going to have a curve. In other words, this was still going to hit the US pretty hard no matter what. It's just we needed to prepare for it. So flatten the curve did not mean no curve. So we're now into one of our spikes here in North Florida. Everybody knows that. And as people can see from the data, at least recently, starting to kind of come down. And I think we'll have this off and on kind of thing as we go through the next year or so until the vaccine is kind of out there and we can kind of deal with it from a more preventive standpoint. So this is a very highly volatile and evolving situation, a lot of political challenges in an election year. Everybody's kind of tuned to it, and that's kind of, kind of where we are at the moment, both locally and I'll say kind of nationally. At this point, any and all questions, and we'll see what we can actually answer, I suppose.
Okay, Bruce, I've got
Sure.
some chats on here.
Yes.
The first one is, what type of mask do you and your family use?
Well, it's easy for me because I can get surgical masks. They're more conforming to your face. You can bend them. They're not as structured as an N95 mask. I don't have one to show you. Here, if you've seen the N95 masks, they have a, do you have one? Yeah. The N95 masks really have a hard plastic and it's really hard on your nose. I've actually, at my colleagues in New York, one of the first things, ear, nose, and throat, one of the first things they saw from most healthcare providers that really were in the trenches up there were nasal injuries from the mask. The bridge of the nose, soft tissue injury from the N95 mask. If you have to wear those for extended periods of time, it's very difficult. And so what do people do? They just don't wear them, or they don't wear them the right way. So the ones that we use in surgery are really that much easier. The newer cloth masks that are kind of designed out there really conform better. The issue with those is the cloth and how well you can get air exchange through it in terms of how easy it is to kind of breathe through it. Sporting events, a lot has been said about athletes, how are they going to do that and wear stuff, the different materials, it's really an evolving process with the materials. But some of that, but some mask is better than no mask. I'll make that kind of. So you can see, this is an N95 mask, and you can see that hard metal. It doesn't bend very well, and over time, it digs into the top part of your nose, and then you don't wear it, and then it's uncomfortable, and you can't. You're supposed to be fitted. They're different sizes, but I have to say, most folks will use them, or if we have to for a really COVID positive case, ICU folks will wear it, but I'm not aware that on a day-to-day, I don't use those in my clinic office. Dan, you want to comment on the mask issue?
Yeah, it's a quick story. So we had a 13-year-old girl who took an AK-47 round through her left foot just above the ankle Thursday night. A trauma alert call to our trauma center, and went in to see her. And of course, because we didn't know her COVID status, we had to wear we had to wear the N95s and all our PPE from the time she arrived in the trauma bay, the time we finished the case at 12 o'clock. So 5 straight hours of wearing the N95 mask. And it's not fun to do it, but as it turned out, the next day, we found out she was COVID positive.
Wow.
Blood everywhere because you had to take the tourniquet off. We had to reconstruct her blood vessels and so forth. But yeah, so we take it pretty seriously. And, as a surgeon, really, really long cases, sometimes you just have to bite the bullet and do it. So far, I still haven't lost any of my natural beauty from wearing the N95 mask, which is a good thing.
So in the hospital situation, just to comment about the PPE thing a little bit, there are the face shields. Those work pretty well to kind of guard against kind of aerosol transmission, except all those have some kind of vent up underneath. My lovely assistant has provided one, custom made actually. Actually, some volunteers in different hospitals have chosen to make them for folks. But they have, this comes down kind of over your face, but air can leak up underneath here. So it's really just for droplet transmission. It doesn't filter air very well. So that's the face shields. They're different models in hospitals, but by and large, that's kind of the PPE kind of thing. So employees in different retail areas are wearing some of those a little bit so their face can be seen more. But that I'll say is the mask story.
So Dan and Bruce, we've got a lot of questions. I'm going to ask one more, and then we'll close the meeting. But if the two of you could stick around so we can maybe answer some of the rest of the questions, that would be most appreciative.
Yeah, I can, Dan. I'm not sure if you have to run, but I can stay around.
Okay.
Go ahead.
So the next question is, can you explain the controversy on the count, especially in Florida? Some argue people being counted multiple times if multiple positive tests, and that very ill people are listed as a death when they likely die more as a result of comorbidity. I may not have.
Yeah, so I'll tackle both issues. So Benjamin Disraeli said there's lies, damn lies, and then there's statistics. Okay, so all of that's true. So I have to say Florida has always had a kind of a robust public health reporting standard, notwithstanding the recent politics of the whole thing. But how you define a case has been an issue from the beginning, and then whether or not you die of COVID or related issues. So you come in with, I'll say, a gunshot wound like Dan described and die, and now you're COVID positive. I have to say, I'm not sure how that one gets reported, okay? But both are true. Patient died, patient had COVID. So some of that is kind of out there. So notwithstanding all that, I think it's fair to say that we have a much better situation with testing than we realized because we tested so many people. We're now north of 50 or 60 track if it's multiple people, the same person getting tested multiple times. So we force employers and employees to do that to some extent. So if you're positive, then you have to be tested, or some employees continue to use the rule that you then have to get 2 negative tests to be able to go back to work. If that's not reported correctly, then it would look like 3 individuals. There's a small hospital in Florida that made the news recently where we had a numerator-denominator problem. 100% of their tests came back as positive. Somebody forgot to check off the box with the denominator. All of the tests that were listed, but they forgot to put in that it was 10 times more tests done. So it was a 10% rate, but they forgot to enter the number for the denominator. So that's where I come to the point about kind of how you watch some of these kind of numbers. So I think on the net of it, we tried to be pretty transparent about the whole thing. Again, politics notwithstanding, the mortality rate is significantly better over the past several months because of what we've learned. And then the risk to each other is probably less than what we think if we do some of the really stuff we're supposed to do, you know, PPE and hand washing and some distancing. We're all kind of waiting for the vaccine to show up, but that is the background, I'll say, kind of to the current conundrum. Okay.
So excellent presentation, very informative. I'm going to stick around for those that want to and go through the rest of the questions, but for those that do need to leave, I want to close the meeting. And as we were introducing visitors and guests, my brother was in the other room, and I wanted to make sure I introduced my brother, Tom. He actually runs a water plant in Alta Vista, Virginia, as well as a politician, and used to work on the as an EMT on the medical team with his wife. And I'm just thrilled to have them both here, and I didn't want to go without recognizing my brother, Tom.
Hey, B.
Yes.
We missed one other guest. Michelle Khalil's son is here and participating.
Oh, nice.
Wanted to make sure that we recognize him.
Welcome. It's always a joy to see the pictures with him and his mother on Facebook.
And there they are.
Thank you, Gary. Stay tuned for the gear. We are working to have the area governors speak next week, and we'll finalize that hopefully here in the next day or two. But you'll for sure find out through the gear, so stay tuned with the gear. Please keep President Tom and his family in your prayers. And then lastly, let's end our meeting with our motto: service above self. One who profits most serves the best. Very good. Thank you, Patty.
Thanks, Patty.
So I'm going to go back to the chat and do these questions. The next question is, we've all heard the allegations about the virus originating in China. The hand sanitizer on my desk, which was a struggle to find, says made in China. I took an at-home coronavirus test last Friday in preparation for traveling this week. Negative, yay. And the components were in a bag labeled made in China. Now, China is in on the race for the vaccine development. Will the U.S. ever allow a Chinese-made or foreign-developed vaccine to be distributed in the country?
So the supply chain issues with this are formidable. So we have collectively over the years, to save a few bucks, offloaded a lot of production for kind of cheap plastic stuff all over the world, including China. And that's how we got stuck. So including PPE, the little cassettes that we use for testing, the swabs themselves are Chinese oriented. So that was the production side of it. So we are trying to reroute some of that, as folks kind of know. Notwithstanding the politics of the situation, we're able to keep up at this point with production for PPE. There are some hotspots that are rumored to have some shortages, but I expect that there are stockpiles. I know that there are stockpiles that will get rerouted to those hotspot areas. In the future, the production side of it is a much bigger political question. The obvious US-Chinese relationship is very stressed at the moment. Notwithstanding all that, that's where the virus originated. But that cannot be denied with what kind of happened. So there are going to be a lot of other politics with this before this is all said and done. Regarding the vaccine, very interesting note for people who follow the news. The Houston consulate, Chinese consulate that got closed, one of the reasons it got closed is part of the investigation had to do with biomedical engineering and IT stuff that had to do with that. And so some of the backstory has to do with stolen technology relative to vaccines. And some of that really is sadly true. So whether or not we will then go buy the vaccine from across the pond, we'll see. I tend to think that's going to be a hard carry. Notwithstanding that, the Moderna trial, the Oxford trial are farther ahead than the Chinese trial and are likely to come to market quicker and sooner, and irregardless of the politics of the whole thing. But there'll be plenty of vaccines to spread around 7 billion people. Even the Chinese vaccine will have plenty of a marketplace to go to.
So if left to the majority of doctors without politics based on science, what would the suggestion be as to the best way to move forward to get us through this in the quickest, safest fashion?
So from a medical scientific basis, several epidemiologists have said if we would just all wear a mask consistently and wash our hands, we could pretty much wipe this out in about 6 or 8 weeks.
Wow.
I think there's I have to say, I think there's significant truth to that. It is spread person to person. There is not a mosquito vector. There are some rumors of cat to cat spread, but there's not enough cats to make a difference with that. This is really person to person spread, and we can control that because we are the people. So if we wear a mask, we wash our hands and maintain a little bit of distance, we can really minimize kind of the spread of the thing. That being said, it is also very contagious. It's not just going to go away. This is something that's going to be with us. So I'm going to say this is likened to the common cold. The coronavirus is a version of the common cold virus, a lot nastier. So it is very contagious. So we're going to have to come up with a vaccine that we can mitigate a lot of this stuff over the next several years. In addition to that, it's also going to be hard to say how effective the vaccine is because, as everybody knows, even the influenza vaccine, you have to take it every year because it tends to mutate. And that's actually already true of the coronavirus. There are several mutations of it that are out there, some of which are thought to be nastier than others. So, but if we get enough herd immunity and we can get enough folks in the population that are pretty protected from it, it will be that much harder for pass from person to person. People forget that there are 50 to 100,000 lives a year lost to influenza. We don't shut schools, we don't close bars, we don't not go to Jaguars games. There are other reasons we don't go to Jaguars games. That's roughly why we accept that as a society and move on. So at some point in time in the not too distant future, we will look back on this too. This will be very difficult while we're all living it. We as a society and also as small business people, Rotarians, to kind of part of the reason for this is to help lead each other through it. I think Rotary has a very unique position of leadership to be able to do that. And I hope we can bring that, give people a reason for hope and moving forward with all this stuff. There is a future out there. We're going to have to get there. It is going to be difficult. We're not done with this. A lot of difficult challenges, but there is a way through.
Okay. Some friends say they've signed up for testing in the line, changed their mind due to long lines, etc., or need to return later, yet they get mail saying they are positive. Oh my, how does that happen? This has happened to 4 different friend groups.
Correct. So unfortunately true. So the testing is not very well controlled. There's lots of potential ways to have error with testing, how you take a test, the sample. So I'm going to say false positives and false negatives. And so some of those numbers are really horrible. And that's why the testing conundrum is the biggest single thing at the moment that really has to get fixed. So we're preventing ourselves from going back to work. Who really has it and who does it? How do you prove, that you don't have it? All those things, sadly, are all true. So the politics behind that, everybody knows what that is, but that's a political challenge, not so much a medical one. They're enormous struggles. Very large corporations, LabCorp, Quest, have contracts for services. My own office, it's hard for me to do my own testing. If I wanted to do them one-on-one, there are rules for me that I can and can't do certain things in my own office. Hospitals are bound by certain contracting. It's a big hot mess with the testing stuff. I'm going to come back to how important masking, hand washing, and distancing are. That will mitigate the problem that we have with testing. Testing is really a non-issue if we do the other 3, to be honest.
Excellent. What is the current train of thought on how long antibodies remain in your system? And even with the antibodies, can't you still be reinfected?
So I just got off a call this morning with some folks kind of all over the place. To everybody in the room, nobody knows of anybody who's been reinfected worldwide.
Wow.
So now we've got 8 months of data, right? Realistically, this goes back to early part of the year, maybe November at the outset. But so far, there's no really documented case of somebody who's been reinfected. There are some individuals who shed virus for a long time. That part's true, but in terms of a true reinfection, not anybody that I'm aware of or the science guys that I know so far. So what that means is when you start developing immunity, it's not just the IgG, IgM stuff, it's what's called humoral immunity, which has to do with your T cells and B cells. And you can remember and have some protection into the future. But just like the common cold, you get sick every once in a while with it, but not as sick the second time. And the same is true for flu. There are certain bad years where the virus is different than what it was last year, but by and large, you have some memory in your immune system that really helps to kind of prevent you from getting that sick again. And I think that will be true for this also. That's why that mRNA virus would be more effective. If we can transfer that kind of genetic immunity quicker, it's much more likely to be more herd immunity for longer.
If it takes 3 days after symptoms start to get a positive test, how does that fit with the asymptomatic passing of the virus?
That's the problem. If we're testing too soon, then we have people running around, which what I'm going to say is really a false negative. People who got tested too soon, they think they don't have it, and then now they have a cold. So there's lots of evidence for that. So I'm going to come back again to the big 3. Wear the mask, wash your hands, and stay at arm's length from somebody.
Have you seen a correlation between people getting cardiovascular exercise and doing better with COVID-19? If so, could that be one of the reasons less than 17 do better than older people?
So our public health folks have done a pretty good job, but partly where I would say the message is not met what our needs are is it's very obvious how unhealthy the US population is in general. we have more obesity, we have more hypertension, we don't take care of ourselves individually very well, and that's partly why we have not done as well with this. So we can't just rely on docs to take care of folks. You're gonna have to do the hard work individually and get out there and do a little exercise and take better care of yourselves. The public health message needs to be the healthier you are individually, you're much more likely to protect yourself from this serious illness. I think that message has been lost in all of this stuff, but I think it's a very important message.
How long are you contagious once testing positive? And there we go.
Okay, so on average, okay, you're about 3 to 5 days after symptoms have stopped that you're no longer contagious. There are very rare individuals who have shed virus 20 days, 25 days. They continue to have positive tests, but whether or not those individuals can really pass it to anybody is really hard to say. But realistically, you know, let's say 3 to 5 days. We try, you know, there's kind of a 10-day rule, so to speak, just to make sure that you kind of can't pass it on. But honestly, it's really about 3 to 5 days.
Okay.
It behaves kind of like the common cold. You're still very sick. If you know folks who have had COVID, a significant case of COVID, they feel like you know what for about 2 weeks. That's not because of the virus. That's because of all the damage the virus did in the first 3 to 5 days. And it takes you 2 weeks to recover, to correct all the lung damage and respiratory damage that's been done. It's not because the virus is still hanging around. The virus is gone, but you have to repair yourself.
So, and this is the last question I'm going to take here on the chat. And then after that, I know Larry had said to me earlier he had a question. So Larry, after this, please ask your questions to Bruce. Can someone that has an immunity to COVID-19 still carry it and spread it?
Probably not. It's very hard to shed virus at that point. So when you've started to make IgG and IgM, it's harder to shed virus. Again, there are very few individuals who can still shed virus after 14 days, 21 days. I mean, a very small number of folks. But you may think you're ill, but you're really not shedding virus per se. So that's why the kind of the 1 week, 2 week rule.
Okay. So prior to starting the meeting, Larry had said he had a couple of questions. And Larry, I believe that the first question you asked is once you have COVID, you recover from it, are there any adverse consequences that linger?
Absolutely. So Dan, you know, spends a lot of time in the ICU, and sadly, for folks who really have the severe condition, it may be weeks or months before you feel better. So the kind of injury you get from this virus is really significant, especially to lung tissue. You get intense scarring, you know, cardiac issues. There's a whole lot of other nastiness that this virus kind of chews up. It stirs up a lot of immune response, inflammatory response. And so we're going to learn a lot about people's individual genetics over the next year. One of the things we're going to learn, and I mentioned that in that genetics kind of social disparity slide, is that some folks are just prone to, if you're going to get it, you're going to get a bad case of it. And so the ACE receptors and some of that conversation has a lot to do with that. So asthma, for instance, folks who have asthma, that's a receptor issue. You're more likely to get inflammatory mediators that do a worse job with you, make it worse. And you're more likely to have more trouble with these kind of respiratory viruses also. There's a lot of crossover there.
Yeah, and the other question that Larry had was around children, and I do believe you addressed that in your presentation, how that they're less likely to get it.
Yes, and there's a weird condition in kids. It's called Kawasaki's disease, and it happens with all viruses, but it's a very low number, and one in hundreds of thousands. And it gives you very peculiar types of side effects and morbidities and mortalities. And COVID has that. So there have been several kids nationwide. It's a very low number, but it's an inflammatory illness. The virus turns on your immune system in such an inflamed way, essentially you turn your immune system against yourself. And so that's kind of where things are. That's why the newer medicines, the medicine I mentioned, it's actually a medicine that's used for rheumatoid arthritis, which is a severe inflammatory illness. And so some of those medicines do a better job in addition to steroids. The anti-inflammatory part of that makes a lot of difference.
Excellent. Bruce, Dan, thank you so much. It was so very informative. If you look at the chat, several people have said that during the chat. That was just a well done presentation and timely. It was very
happy to help. If people have individual questions, you can always call me.